the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Today's podcast, you got Chuck Dowell, Miles Gilbreath, and myself discussing how to handle fractures if you're not sure if it's a fracture, possible bad things that can happen, such as infections after injections or angulated fractures where you're not expecting an angulated fracture, or if somebody refers you something and you find something different. I mean, I can ask you this, Miles, you probably had some experience with this, but Chuck, I know you have. How many times do you get the x-ray coming in on a CD that, probably somebody's secretary took, and it's like, half oblique, half lateral, upside, one view of the forearm's going one way, one's going the other, and, a Caspergram, which means you see like a faint shadow of soft tissue and that's it. It's not as much with computed radiology. It used to be with films, but, and anybody listen to this, folks, I would rely on my own cognizance looking at something, as far as an x-ray. And if I can't read it, I'm going to get some more regardless. And I tell the patient, and here's another mistake that I made back when films were coming through. I told the patient this was technically unacceptable from a referring doc. And oh boy, that went to the chief operating officer. I got in big trouble for that. So don't say that it's technically inadequate. Just say, I can't see what I need to see. I need to get a couple extra views. But anybody listening to this that, is not a medical person, I mean, you'd be surprised at the poor quality of some of the x-rays that come through from referring docs.
Yeah.
Yeah. And the other point, let me just throw this in too. Don't rely on the reading of the radiologist. Now the MRIs, sure, I don't look at enough MRIs to feel comfortable reading it, but regular x-rays, an ED report or a family doctor, I've got a wrist fracture and it turns out to be a supracondylar humerus fracture, or, you got to do your own due diligence, if you will. You got to, read your own x-rays. You got to look at your own x-rays. I can't tell you how many times I've had somebody follow up from the ED that they missed something, or that the radiologist read something that, that they relied on the report that wasn't quite right. So that happens not infrequently. So I would advise you to, everybody listening, especially our new folks, make sure you read the x-rays yourself. You look at the films, you make the decision. Don't necessarily rely on somebody else.
Yeah, I see. Georgia is not a certified radiology technologist state. And so pretty much anyone in physician's offices, urgent cares can end up shooting an x-ray. I have a friend and colleague who works in urgent care, and she contacts me a lot because she has to shoot her own and just knows that she's not getting great x-rays. And so I definitely review the imaging that the patient had prior. And I have a very low threshold of getting what I describe to the patient as standard orthopedic imaging, standard views, which aren't necessarily present before. And so, yeah, I'm quick to get my own x-rays as long as the patient is okay with it and it's clinically appropriate to get x-rays. We could have our own podcast about things we see from urgent cares. I have one picture saved, and I should send it to both of y'all. It is the kid. I think the kid had maybe a buccal fracture, maybe a Salter-Harris 1 fracture, and I'll kind of talk about that a little bit, how I approach it. But the kid came in with a forearm tube cast. The wrist was not immobilized.
What? A forearm tube cast? What is that?
It's not a cast. I mean, it's the only way I can describe it. Nothing was immobilized. He had a tube of cast material around his forearm that stopped proximal to the wrist and stopped distal to the elbow. It was hilarious. And this was one that I couldn't help but take a picture of and say, yeah, it's a good thing they sent you here. We're going to take care of this. But I'm very careful not to put down any other provider, right? I'm very careful not to say, oh, this was wrong. They were wrong. They didn't tell you right. I just say, we approach things a little differently in orthopedics or what have you. But yeah, I'll text both of you guys this picture. It was one of the funniest things I've ever seen. When it comes to kids with growth plates, I see a lot of young adolescent, high school age athletes. I see them immediately after their injury at the high schools that surround my clinic. From my experience, they're pretty much always tender over the growth plate, at least acutely. And so, the way I describe Salter Harris 1 to the family is, hey, they're chock full of growth plates. They're growing like a weed. Anytime that I see tenderness over that growth plate, whether I see nothing on the x-ray or not, I classify it as a Salter Harris 1 fracture. And then I proceed to immobilize it appropriately for a wrist, usually like a good long cock up wrist brace. And then I tell them, hey, let's have you follow up with one of my specialists within the next week or early next week and reevaluate. And I tell them, hey, if you come back for your next visit and they tell you, oh, this wasn't a fracture, I love that, right? I'm okay with that. But right now, your child is tender there. And so, technically by the book, it's a Salter Harris 1 fracture. And I know a lot of times when they come back for follow-up, they get turned into contusions or sprains or whatever they want to call it. So that's just kind of how I approach that pediatric patient with seemingly normal x-rays, basically over immobilized for a short period of time.
I agree with you 100%, Miles, and I think that's a great way to approach the patient. And as we mentioned before, I think as orthopedic providers, we have to trust our clinical examination, which is, to me, one of the most important parts of seeing patients, especially pediatric patients. And I agree with you completely, Sam. I never trust films. I never trust reports. I've seen a lot of fractures that are missed necessarily by the radiologist reads. But again, I have the benefit of the clinical exam and retrospective looking at the x-rays based upon where the clinical tenderness is at. And, I agree with you, Sam, as well. I apologize, Miles, as well, that I have a low threshold of getting new x-rays in the office. And patients are usually okay with that. If you say, hey, these x-rays maybe don't show some subtle findings, your clinical exam is concerning to me that something more significant is going on, I'd like to get some new x-rays just to make sure that we don't see something subtle on there so we can kind of treat it appropriately. They're usually fine with getting those new x-rays. I don't understand why the emergency room insists on doing these oblique views of the knee and what they necessarily obtain out of those. But those are pet peeve of mine because I don't know what they're getting out of those views. But again, I think as Sam said, one of the things that young providers can take out of this is trust your clinical examination. If the examination and the mechanism in the patient, you have a 5-year-old that won't put weight on their leg, doesn't correlate to the x-rays, which could potentially be read as negative, then immobilize it. Have them restrict their weight bearing. As Miles said, have them return in 7 to 10 days. Let the fracture and or the injury declare itself, because all injuries are going to hurt for 3 to 5 days. And by day 7, hopefully it's declared itself. Sometimes you'll see that fracture line become more apparent due to the bony absorption around that fracture line that happens around that 7 to 10 day period. So, as you said, Miles, I do the same thing. If it's clinically tender over the growth plate, if they are concerning for an occult fracture where they have tenderness over the bony prominences, you don't lose anything by immobilizing them, by restricting their activities, by having them follow up saying, hey, we want to let this kind of declare itself and reevaluate. And again, as you said, Miles, if it's proven not to be a fracture, then we'll remove the splinting and allow you to participate in activities. And if it's proven to be a fracture, they'll probably further immobilize you, but at least then you've protected them during that time period.
Yeah, I agree with everything you guys are saying. I mean, it's, and I go back to it's a practice, guys. Not everybody knows everything, but after a while, once you've done something and you've seen something 100 times, I mean, the old saying, common things occur commonly, and something about a zebra and all that. But
Mhm.
I think, I just trust your own acumen, trust your own judgment is very important.
And, while I'm very conservative with these pediatric fractures, I've also had to learn the practice of being less aggressive with some others. So for non-displaced distal fibula fractures early on, for people that were tolerating really well, maybe they had an injury a week prior, um, I would put them in a brace. I was more functional bracing for a distal fibula fracture and talking about modified activity. And if something hurts, don't do it. And then I had one patient who was very, very active, maybe had her fracture on Friday or Thursday. I saw them on Monday or Tuesday. They were still walking, they were still running, but it hurt. Non-displaced, no significant intra-articular involvement. And I went ahead and put her in an ankle brace and gave her my spiel. When she followed up with the foot and ankle team, she complained of pain after walking 3 miles. And the note from the foot and ankle team from a younger colleague of mine, it's kind of an interpersonal issue. It kind of felt like she threw me under the bus in the note. And so I had to, we had to deal with our APP stuff and say, hey, you can disagree with how I treated it, but, don't throw me under the bus in the note. Right. And so now I've completely adjusted the way that I treat those fractures, and I'm more aggressive on those. Right. I put them in a boot. So I've augmented the way I practice that. So that was another occurrence that came to mind as we were discussing things.
Yeah, I think the take home from that, Miles, is that you saw the potential error and you adjusted what you can control and made the appropriate adjustments to better treat the patients and to reduce risk of complications to the patients. And I think, as we're all discussing from all of our stories and everything we're sharing, I think that's what a lot of the younger providers can potentially learn from this, is that if there's something under your control, if there's something that we could correct, such as changing the gauge of the needle that we use to draw up the medication, changing the procedures that we use to wipe those multi-vials to make sure that they're appropriately cleaned, your procedure of how you do injections and making sure you're appropriately cleaning the skin prior to, doing it, whatever it may be. Those are controllable factors that I think we have to take upon us to make those changes and to control those to reduce the risks of these complications happening. And if a mistake happens, then learn from it and adjust your practice appropriately, so potentially that will never happen again. And I think that's what I've learned over the years. And when I mentor PA students that come in, I try to pass that along to them, that you're gonna have complications, you're going to miss things, but make sure that you don't miss it again. Make sure that you make the changes. Don't trust the emergency room x-rays that are read as negative. You don't get any new x-rays. They go in and see your supervising physician or your colleague, and they get new x-rays and it shows the fracture. And they're like, well, why didn't you see this initially? Well, you didn't have access to the images. You just trust the radiologist reads. So again, make sure if something like that happens, you're correcting those and not letting it happen twice, I think, is the important thing.
Stay tuned next week for the next part of our discussion about mistakes and what happens when they happen. Listeners, I hope you have taken advantage of our new membership drive. Please look at paos.org for details on how you can get some free CME before the end of the year.